Hi, I'm Natalie. We're here doing our 509 assessment, head to toe. Here with the patient, I've performed hand hygiene and the patient is in a gown. First, I'm going to start with the neurological system. So can you tell me your name?
Eliana.
And what day it is?
April 14, 2025.
And who's the president?
Trump.
And where are we?
In Evanston Hospital.
Great. Okay, so patient is alert and oriented ×4. I'm now going to move on to the cranial nerves. So I'm going to pretend like I have a vial of something to smell in here, and I'm going to check the patency for each nostril.
Vanilla.
Great. Okay, now we're going to move on to cranial nerve 2, the optic nerve. Normally we would start with the Snellen test to test for vision. We don't have one, but if I were to, I would stand 20 feet away and have the patient read the bottom line. Next we'll move on to peripheral vision, so I'll have you cover the same eye, and then tell me when you see my fingers.
2. Yep, I see them.
Okay, and then the other eye. Okay.
See them. You see them. You see them.
Great. Okay. So cranial nerve 2, the optic nerve is intact. We'll now check for cranial nerve 3, 4, and 6, the oculomotor, trochlear, and abducens. So first I'm going to start by moving my finger in an H motion. Please just follow your eyes with my finger. Great. And check for patient. Good. Now I'm going to take a pen light and check for perla. Pupils equal, round, reactive to light, and accommodation. Great. Cranial nerves 3, 4, and 6 are intact, and there's no lid ligertosis. Now I'm going to assess for trigeminal nerve. First I'm going to palpate your temporal and your masters. Go ahead and clench your jaw, open and close. Good. Motor is intact. I'm going to have you close your eyes now and tell me where I'm touching.
Forehead. Left cheek. Right cheek.
Good. Okay, now I'm going to take a cotton swab to assess for the corneal reflex. So go ahead and open your eyes. Good. Good. Corneal reflex is intact. Trigeminal nerve is intact. Now I'm going to move on to the facial nerve. So first I'm going to have you lift your eyebrows, clench your teeth, puff out your cheeks, stick out your tongue, move side to side. Great. Okay, I'm going to have you close your eyes and let me know if you feel me touching. Good. Facial nerve is intact. Now I'm going to move on to the cranial nerve 8, the acoustic and vestibular cochlear. So normally we would have a tuning fork. So I would prime the tuning fork for the Weber test, place it on top of her, and you would hear, normal would be hearing lateralization in both ears equally. Next I'm going to perform the Weber test. Rhine test. So I'm going to prime the tuning fork, place it on her mastoid bone right here. Once they're done, once they stop with hearing noise, I'll move it to over here, and that should be air conduction. Air conduction should be greater than bone conduction, which would be normal. Now I'm going to perform the Romberg test, so I'm going to go ahead and have you stand up. Close your eyes. Good. Patient, do you feel unbalanced or anything? No. Good. You can open your eyes. Go ahead and take a seat. So the patient's Romberg is negative, so that's good. We're now going to perform the whisper test, so I'm going to whisper into each ear, and you just repeat what you hear, okay?
33. 55.
Great. Cranial nerve 8 is intact. We're going to assess for 9 and 10 together, so I'll go ahead and have you stick out your tongue, move it from side to side, open your mouth. Good. Uvula is midline, and the cranial nerves are intact. Now I'm going to assess for the spinal accessory, so I'll have you shrug your shoulders. Good. And then I'm going to place my hand on your face. Go ahead and relax your shoulders and try and push your head against my hand. Good. Other one. Good. Those are intact. Okay. Now we're going to move on to the cerebellar and fine motor. So first I'll have you stand up. We're going to assess your gait. I'll send you walk to there, to the camera, and back. Good. Gait is steady and smooth. You can go ahead and take a seat again. We already did the Romberg test. Now I'm going to have you touch your finger to nose to my finger.
Finger to nose.
To my, yes, so keep doing that. Good. Now we'll check for rapid alternating movements. So we'll have you put out your palms and flip them over back and forth. Great. Excellent. Okay. Now we will do the pronator drift. So I'll have you close your eyes and stick your hands out. Good, no pronator drift, that's normal. Go ahead and put your arms down. Okay, now we're gonna assess for primary sensory. So I'm gonna start by just superficial touch. So I'll touch you with your eyes closed, and you just tell me where you feel, okay?
Okay. Both arms. Both legs.
Good.
My temporal.
Good. Okay, now we're gonna start with superficial pain. So I'm just gonna take the tip of a pen and touch each spot, and you're gonna repeat where you feel you'd be touching, okay? So go ahead and close your eyes.
The left arm. Right arm. Left leg. Right leg.
Great, okay, so that's intact. Because those are intact, you don't need to go further and do the deep pressure pain. Now I'm going to do the vibration test. You can open your eyes. I'm gonna prime the tuning fork, and I'm gonna place it on a bony prominence, and you let me know if you still feel that vibration, okay? Feel it still? Okay, great, okay. So that is intact. And then now we're gonna do joint proprioception, so I'll have you hold out your finger. So I'm going to hold on here, and you just tell me if I'm going up or down, okay? Close your eyes, yeah.
Down. Up. Down.
Great, okay, joint proprioception is intact as well. Now we're gonna do primary cortical. So first I'm going to have you hold out your palm, and then close your eyes and tell me if I'm doing 1 or 2, okay?
1, 2.
Okay, good, and then I'm back here.
1, 2.
Okay, good. So that was actually the 2-point discrimination, sorry. Now we're gonna do the graphesthesia, so I'll have you hold out your palm, and I'm gonna place an object in you, and then just tell me what that object is.
Okay.
Good, okay. Now I'm gonna do the graphesthesia, so that was sternogenosis. Now I'm gonna draw a letter in your palm, just tell me which one.
Okay. H.
Good, okay. Now we're going to move on to point location, so I'm going to touch you at some point on your body, and with one finger, touch that point again, okay? So go ahead and close your eyes.
Okay.
Great, okay, patient touches the right deltoid, that is correct. Now we're going to assess muscle strength, so I'm gonna have you hold out your palms. Good, go ahead and push against me. Good, pull back. Good, same thing with your legs, push forward. Good, pull back. Good. Okay, so muscle strength is a 5 out of 5, which is normal. Now we're gonna do the deep tendon reflexes. So for the bicep, I'll have you relax your arm here. I would have and I would hit it right here. I'll use a pen for this. Normal would be a brief flexion of the bicep here. For the brachioradialis, I would find the tendon here and tap against it, and we would see flexion of the wrist and the muscle a little bit. For the tricep then, I can kind of support the patient's tricep here, and I would hit the back here, and you would see extension there. Now we're gonna do the patellar. So I would hit on the patellar here. Good, and you would see that. And then after that, we would do the Achilles. Good, and you would see plantar dorsiflexion. And then from there, we are now going to assess the meningeal. Okay, so now we're gonna assess the superficial reflexes. We'll assess the abdominal ones during the abdominal section. The cremastic reflexes for male patients, you would stroke the inner thigh, and on that same side of the inner thigh, you would see the scrotum rise. We'll now assess for plantar reflex. So I'll lightly stroke the lateral side. Good, and a normal response would be plantar flexion, which we see. Great. And then now we'll assess for meningeal irritation, so go ahead and lie flat. So I'll have you lift your head here. Good. Any pain with that?
Nope.
Nope, good. So that would be nuchal rigidity is negative. We're gonna do that again. And watch her legs, that's for the Brzezinski, so go ahead and lift your leg, or lift your head, good. Her legs did not rise, so that means the Brzezinski is negative. We'll now do the Kernig's test too. So I'm going to raise your leg, good, down, and good, down. Any pain or irritation with that? No, and I didn't feel any resistance, so those are negative as well. Okay, so now we're gonna do our head and neck assessment. So we'll start with the inspection of the head. It is midline, normocephalic, no sign, asymmetrical, no signs of deformities. I see normal female hair distribution, and then the scalp doesn't appear to have any lesions on it. Her face is symmetrical, no abnormal features, no involuntary movements. The neck looks like there's normal muscle development, no webbing or fullness at the base. Trachea appears to be midline, no thyromegaly, no JVD or carotid pulsations. And then I'll have you assess for the full range of motion. So go ahead and put your neck down and back, and side to side. Good. And that way. Yep. Good, so that was a full range of motion, looks good. Okay, so now we're going to start with palpation. So I'm gonna start by palpating the head. Normal hair texture, no tenderness, any there, no deformities, no masses, good. For the face, I'm gonna palpate the temporal arteries, good. I'm gonna assess the TMJ, so go ahead and open and close, good, no crepitus, and then there was no thickening or hardening of the temporal arteries. For the Schulbeck sign, I'm gonna tap here, good, no muscle flicker, so no signs of hypocalcemia. I'll assess for the salivary glands now with the parotid, the submandibular, sublingual, no signs of inflammation or pain with that, no, okay, great. And then now we're gonna assess the sinuses, so we have the maxillary and the facial. Good, okay, so now I'm going to assess the lymph nodes. We'll start with the occipital, the preauricular, postauricular, the submandibular, sublingual, and the submental, the posterior, anterior neck triangle. And then the epitrochlear is in the elbows here, and then you would have the femoral and the inguinal and then the popliteal there, good. And then now I'm going to also assess for the, and the trachea is midline. I'm gonna go behind and assess for a thyromegaly. So go ahead and swallow. Good, I feel no thyromegaly, that appears to be normal. Okay, and then now I'm going to auscultate. The thyroid was not enlarged, so I don't need to auscultate the thyroid, but I'm gonna, with my bell, listen for any bruits in the carotid artery here. Good, no bruits heard there. Okay, now we'll perform the ear, nose, and throat assessment. So I'm gonna start with inspection of the ears. Okay, sorry, they look bilaterally about 10 degrees set from the skull, which is normal. I'm gonna assess the pinna, which looks well formed, pink, no lesions, no discoloration. The external auditory canal looks pink, uniform, no signs of inflammation or exudate. I'm gonna now use the otoscope, which I would have. I would pull the pinna up, look in, and I would see the temporal membrane to be like a pearly translucent gray. I would see the bony prominence, and on the left ear, the light reflex would be at 5 o'clock, and on the right ear, the light reflex would be at 7 o'clock. We already conducted the hearing assessment during the neurological system, so I will not go through that again. I will now inspect the nose. The nostrils are patent bilaterally, the septum is midline, no signs of deformity, and the turbinates are pink, no erythema, and they're moist. The septum is midline, no signs of perforation, and no rhinorrhea. I'll now assess for the throat. So I'll go ahead and have you kind of open your mouth and smile for me. Good, lips and mouth look pink and uniform color. The buccal mucosa is pink without lesions. The Stenson's duct do not appear to be inflamed. And the teeth, I'll have you open your mouth. Good. Good, all teeth are intact, 1 through 16 from right to left on the top, and 17 from 32 from the left to the right on the bottom are all present. The uvula was midline, it rose symmetrically. The tongue, I'll have you stick out your tongue again, go on side to side, good, that was symmetrical with motion. The floor of the mouth was moist, no lesions, the frenulum was intact. Orton's duct did not appear to be inflamed either, and the tonsils were pink, 2 out of 4, with no exudate and no postnasal drip appeared to be present either. I'm now going to palpate around the ears to assess for any tenderness or masses. I'll assess around the mastoid process here, around the ears. Any tenderness or pain with that? No? Okay. Okay, so now I'm going to perform the otoscope exam. So I would pull the helix up, look in her ear. I would see that the temporal membrane would be translucent pearly gray. The light reflex would be, the bony landmark is visible. The light reflex would be 5 o'clock on the right ear and 7 o'clock on the left ear. Okay, we'll now perform the eye assessment. I already completed the visual acuity, peripheral vision, and the extraocular motion during the neurological assessment, so I won't repeat that. To do a near vision test, we would take the Rosenbaum packet, and I would have the patient read the card. And then their reading distance would be about 14 inches, and they should be able to read the normal print from there. I'm now going to start with inspection of the orbital area. Sorry. So the eyebrows are full symmetrical, the eyelashes are everted bilaterally, and they both look symmetric. The papular fissure is symmetrical, horizontal, no edema, lesions, or discoloration there. The lacrimal atlas looks like it is no redness or swelling noted. The sclera are white and free of lesions. The conjunctiva, I'm just gonna pull down right here really quick. Good, they look pink, moist, no signs of infection or exudate. And then the corneas are clear, round with no lesions. I already did the corneal sensitivity test with a cotton swab during the neurological assessment, so we don't need to repeat that. And then I'll do a corneal light reflex. So I would have the fundoscope and I would shine the light. Good. And I would see bilateral red light reflexes. And then the iris and the pupil are brown, bilaterally symmetrical. And again, we already did the pupils equal reactive to light and accommodation during the neurological assessment, which was intact. I'll perform the fundoscope exam. So I would see again the red light reflex bilaterally, and then the disc would be bright yellow, round with well-defined borders, and the vessels would be intact, and the retina is uniform in color with no lesions. I will palpate the lacrimal apparatus. So good, no swellings, inflammation, or signs of lesions with that one as well. Okay, now I'm going to perform auscultation in the 5 areas with the bell to listen for any murmurs or extra heart sounds. So aortic, pulmonic, Erb's point, tricuspid, mitral. I don't hear any extra heart sounds or murmurs, and the pontomaxillary impulse is about 2 centimeters. Okay, now we're going to do the vessel inspection. So skin color, lesions, no edema. They're uniform in color in the periphery, no discoloration, no signs of edema in the legs either. I'm going to assess the arterial pulses. So I'll start with the temporal, the carotid, good, the brachial, I'll do the radial, the ulnars, and then you would have the femoral and the popliteal, posterior tibialis, and the dorsalis pedis would be here. Good. We would now perform the Allen's test. So I would have the patient make a fist with their hand. I would occlude both radial and ulnar arteries, and then I would release and look for reperfusion within 6 seconds. So that looks to be normal. Good. So that artery is patent. And now we'll perform Hohmann sign. So I'm going to have you flex your feet here. Any pain with that in your calf? No. Good. So that's negative. So that is normal. Okay, so now I'm going to assess the abdomen. I'm going to start with inspection of the surface characteristics. Normally the patient would have their shirt off so I could fully see, but for this purpose we'll leave the patient clothed. So the skin is uniform in color. I don't see any Grace, Turner, or Cullen sign, which would be the ecchymosis around the abdomen or the flanks. None of that is present. The venous pattern is not visible. The contour is flat and symmetrical. There's no lesions, scars, striae. The pulsations are visible, and there is a slight motion present with the respirations, which is also normal. And then the umbilicus is midline and inverted, and there is no hernias present. I'm now going to auscultate the stomach with my diaphragm in all 4 quadrants to assess for bowel sounds. Good, bowel sounds are normal, active. Now I'm going to assess the abdominal arteries with my bell and listen for any bruits. So we have the aorta, the renal, the iliac, good, and the femoral. Good, no bruits are present there. So now I'm going to start with percussion in all 4 quadrants. Good, and I hear tympany without, which is normal. Good. Now we're going to assess the liver span. So the liver is on the right side. It should be between 6 to 12 centimeters at the mid-clavicular line. We don't need to percuss on the upper border because that's gonna be along the nipple line. And then on the lower border, we're gonna percuss from the bottom towards the costal margin. And then where I start to hear dullness is where I would see the liver. Good. Good, and I'm starting to hear dullness as I move in that direction. Now we're going to assess for liver descent, so I'll have the patient take a big, deep breath, and I will percuss along the abdomen. Good, and I feel the dullness descend about 1 to 2 centimeters, which is normal, indicating that the liver is normal size. Now I will do the splenic percussion. So the spleen is on the left side of the body. It is along the 11th intercostal space on the anterior axillary line. Normally you would hear tympany, which is normal, and then large spleen would mean that it was that you would hear dullness then. So go ahead and take a big deep breath for me. Good, good, okay. And then now we're going to perform the liver scratch test. So I will take my stethoscope, and then I'm going to scratch along the abdomen, and as I get closer to the liver, I would hear an increase in the sound. Good, so that's normal. Okay, now we're going to do the abdominal reflexes. So I'm going to stroke each side of the umbilicus, and you should see that the stimulus, that the umbilicus moves towards the side of the stimulus. Good, that's normal, good. Now I'm going to move on to light palpation, which is just about 1 to 2 centimeters. I don't feel any masses. Now I'm going to move on to deep palpation, which is about 5 to 8 centimeters. No guarding, no rigidity, any pain, no, good. And then again, no masses. The liver is on the right side, so I would palpate right there. And then the spleen on the left side there, which is hard to palpate, and you shouldn't force it or else you could cause injury to it. And then I don't feel any organomegaly. I'm gonna have you sit up now and face that direction. We're gonna assess for CVA tenderness. I'm gonna palpate the kidneys will be right about here, good. Any pain with that?
No.
No, good, so CVA, no CVA tenderness present. Okay, we'll now perform the chest and lung assessment. So I'm gonna start with inspection of the respiratory rate and pattern. Appears to be regular, non-labored, no signs of accessory muscle use. Respirations are at about a 16. Now the skin, lips, and nails look pink, well perfused, uniform in color. I'm going to assess cap refill less than 2 seconds, which is normal. The thorax elliptical looks to be symmetrical, and the anterior to posterior transverse ratio appears to be about 1 to 2, which is also normal. And then the costal angle is symmetrical and less than 90 degrees. The venous pattern is fine, symmetrical, and the not seeing a venous network would be within normal limits. No anatomic abnormalities such as scoliosis or kyphosis present. I'm now going to palpate, so I'll palpate the trachea. Appears to be midline, no tenderness, crepitus or pleural friction rub. I'm going to palpate the chest wall here. That feels good. Okay, now I'm going to assess for chest excursion. So I'm going to come to the back here and go ahead and inhale and exhale. Good, that is normal, which is about a 2 to 3 centimeter expansion and excursion. Now I'm going to perform tactile fremitus, so I'll place my hands on your chest and you just say 99, okay?
99, 99, 99.
Good.
99, 99, 99.
Good. And as I go into the periphery and the bases, it is diminished bilaterally, which is normal, and at the costal angle of Louis, I hear the tactile fremitus present, which is normal. Now I'm going to perform percussion. So I'm going to take my middle index finger here and tap along the lung fields. I should hear resonance throughout, which is normal. Good. Okay, now I'm going to do the diaphragmatic excursion. So for this, I'm going to go to the back side here. So I'm going to tap down to assess when it turns from resonance to dullness, mark that spot. I'll have the patient take a deep inhale. Good, I'll palpate down, and then the marking of, go ahead and breathe out for me, and then the marking of where that change is from dullness to the resonance should be about 4 to 6 centimeters. Now I'm going to auscultate bilaterally for breath sounds. So I should hear tracheobronchial up here, brachiovesicular, between the scapula and vesicular throughout the lung fields. Normally I would make sure to listen bilaterally and the patient would have their shirt off. Now I'm going to perform whisper petriloquy. So I'm going to have you say, and this is with my diaphragm, I'm going to have you say 1, 2, 3.
1, 2, 3. 1, 2, 3. 1, 2, 3.
Good. And bilaterally that is muffled, which is normal. Now we're going to do bronchophony, so I'll have the patient say 99.
99. 99. 99.
Good. Again, I would do all of these tests bilaterally. That was muffled, which is normal. Now I'll have you say E.
E. E. E.
Good. That's normal. It sounds like E to me. Abnormal would be it changing to sound like A. And during the abdominal assessment, I misspoke and I do not see any peristalsis or pulsations, which would be normal. Okay, we're now going to do the heart and blood vessel assessment. Before I said that chest excursion was 2 to 3 centimeters. It's actually normal is 2 to 3 inches. My apologies. Okay, so now we're going to assess the heart and blood vessels. We'll assess by the JVP. So the patient is sitting at 30 to 45 degrees. I'm going to assess right at the angle of Louis where the dissension is, and it should be about 2 to 3 centimeters above the angle of Louis. If it was greater than 4, that would be abnormal. Now I'm going to assess the hepatojugular reflex. So I would apply pressure to the abdomen for about 30 seconds. Normally you could see the venous rise in pressure in the EJ and the IJ, and then I would let go, release that pressure. Within 20 seconds or a few cardiac cycles, it would return back to normal. I don't see any hepatojugular dissension or JVG dissension right now. So good. Okay, I'll have you go ahead and sit up. Now we're gonna, again, inspect the skin, lips, and nails. They look pink, moist, and the cap refill is, again, less than 2 seconds, which is great. Now I'm going to inspect the pericardium for pulsations. So I would palpate each area. So I would palpate the aortic valve, which is gonna be at the center intercostal space, right sternal border. The pulmonic valve, which is at the left sternal border, second intercostal space. Erb's point, which is third intercostal space, left sternal border. The tricuspid valve, which would be at the fourth intercostal space, left sternal border. And the mitral valve, which would be at the fifth intercostal space, mid-clavicular line. That would also be where I'd expect to feel the point of maximum impulse. I'm now going to auscultate those 5 areas with my diaphragm to assess the heart sounds. Okay, so I'm checking the aortic, the pulmonic, Erb's point, tricuspid, and the mitral valve. Good, and S2 is louder at the upper sternal border and S1 is heard down at the apex. Now I'm going to assess with the bell